a pleasure to speak to you all today. Let's see if I can go ahead. I have no disclosures. I'm on the board of directors for a nonprofit that deals with kids with ADHD, autism, and anxiety. The objectives today are to review some of the information about ADHD, something that I know that we all as pediatricians see all the time, and to review some of the behavioral recommendations, medication recommendations, as well as to take a little bit of time about the group of adolescents that can be hard to treat, and then end with some emerging pharmacogenomic capabilities. So we know that ADHD has been around for a long time, described even before the early 1900s, and it was about in the late 1960s that NIH conducted the first trials of medication. The DSM-1 called ADHD minimal brain dysfunction, so we've come a long way in recognizing that this is really a pattern of hyperactivity, inattention, and in the DSM-5, the major difference is that it's really recognized up to that the diagnosis can come as late as age 11 to 12. So ADHD inattentive type requires at least 6 of these characteristics, notably distractibility, inattention, failure to follow through. And hyperactive-impulsive, similarly, at least 6 of these criteria in both hyperactive as well as impulsive domains, being fidgety, up and out of their seat, talking excessively, blurting out answers, and just not able is that these symptoms interfere with functioning. So it's not just that they're present in somebody's mind, but they really are interfering with function at home or at school or in other pursuits. They must be pervasive and not just in one context, and not in the course of another comorbid or coexisting condition. Interestingly, the presentation of ADHD may vary by age. And we see inattentive type being primarily inattentive symptoms and not meeting criteria, not having at least 6 of the hyperactive-impulsive domain criteria. Hyperactive-impulsive would similarly just meet criteria for the hyperactive-impulsive domain, but the combined type meets criteria for both. For preschoolers, hyperactive-impulsive is the most common. Inattentive is most common for school age and into adolescence. The neurobiology of ADHD is interesting and involves the prefrontal cortex, and which really organizes attentional and executive functioning skills. Neuronal circuitry that sort of links with the prefrontal cortex is part of the neurobiology of ADHD, but also the neurotransmitter systems that really function in those neuronal circuits that involve dopamine, norepinephrine, serotonin, which is part of how the medications are targeting and helping to address the ADHD profile. Genetics is important. Probably about 40% of kids with ADHD have a first-degree relative that also have that diagnosis, and if both parents have that diagnosis, that is even higher, even up to 70%. We know from surveys across time that ADHD has been very common, but what I think is really interesting is that despite the type of survey, the method, whether it's a part of the census or a phone survey, ADHD diagnosis has increased by 4% per year. And we can see here that by state, can see here by state that ADHD is quite common, including in Michigan, where in 2011, the rate of ever having a diagnosis of ADHD for children 4 to 17 years of age was above 11%. This translates to, as of 2016, over 6 million children who had ever had a diagnosis of ADHD. This means about 9.4% nationally who ever had a diagnosis, and over 8% who have a current diagnosis. So it's a frequent problem that you'll see in your office. General pediatricians actually do a really good job of inquiring about ADHD, and this is a comparison of a periodic survey through the American Academy of Pediatrics comparing 2004 to 2013 report from pediatricians in practice. So the all are all pediatricians, and the general pediatricians were about 65% of the group. The difference between 2004 and 2013 was that 2013 added sort of, you could, do you inquire or do you inquire and screen? And we can see that between these two surveys, general pediatricians rose by 10% in their inquiry. However, and screening. However, the treatment and management just has to do with those who were diagnosed with ADHD. So we can see that general pediatricians are still referring about 20% of the cases that they diagnose. So if you are going to be caring for ADHD longer term in your practice, or would like to be updated on how to evaluate for ADHD, there are guidelines to help you. Currently, the Academy for Child and Adolescent Psychiatry doesn't have a current updated version for their guideline, but there are many practice guidelines, including at Michigan Medicine, and ours is from 2013. This is from a 2014 American Family Practice article written by the authors of the Michigan Medicine Guideline, and it takes you through screening, the evaluation phase, how to sort out whether this is developmental deviation or is this due to another disorder, and then finally into treatment. And we'll begin with the screening, which I would suggest is not just at health supervision visits, but it's any opportunity that you have, because kids don't come to see us very often after their immunizations are up to date. So how is the child doing in school? Are there any concerns about learning or in play with others or problems completing their work? And consider an ADHD evaluation if you're hearing some threads that suggest that the child is overactive, daydreaming, impulsive, and academically underachieving. Next, then, would be the evaluation for ADHD, and this really is looking across settings to gather information, and I would say cannot be done in one of the primary care usual health supervision visits. This is probably the time to bring back the child for a bit longer visit where you can really inquire about how did the concerning behaviors begin, how have they progressed, what have you tried so far, and to understand, is there a family history suggesting that the likelihood of ADHD is a bit more. And then to consider gathering some information from schools and using rating scales, validated ADHD instruments, to be able to get an anchor for whether these behaviors are out of line for normal, for the child's age. In choosing a rating scale, though, it's important to consider what the scope of that scale is, whether it has good sensitivity and specificity, whether it even covers the age range of the child that you're seeing. So an example is the Vanderbilt scale, which is free, that's good, and at least version 1 of the toolkit is free and online at the NICHQ at the link. However, it really is validated for 6 to 12-year-olds and may not be your best option for a teenager or a 4-year-old in your practice. In addition, it isn't age-normed or gender-normed like some of the other rating scales available to you, like the Conners rating scale. Most of the scales up here are proprietary and do cost, but again, the Vanderbilt does not. The rating scales provide some of the information you need in consideration of the diagnosis, but it's really important to recognize that it is not diagnostic. And in fact, looking at the rating scales, it's important to kind of know what you're seeing in terms of the T-scores, or if these T-scores, the results of the rating scales, come to you from a school evaluation. So a T-score average is 50 with a standard deviation of 10 points. So scores that are 2 standard deviations above are clearly above normal range for age and gender. Here, for this child, we can see that some of the items are reaching that T-score of 70. Whoops. But for this child, we can see that the profile really fits for a concern for ADHD, and this rating scale would be supportive. Next, then, would be evaluating for coexisting conditions. You've heard this morning about a number of two other mental health conditions that are really within your differential in considering the child who's hyperactive, irritable, and hard to control. So a common comorbid or coexisting condition, among the most common, are anxiety disorder, oppositional defiant disorder, and learning problems or learning disability. Other conditions that can be co-occurring include early toxic exposures like fetal alcohol spectrum disorders or genetic conditions. ADHD may be, an ADHD presentation may be your first indication of a child with Fragile X, or even you may see this in the context of a child with Down syndrome. I'll come back to sleep disorders in a minute because sleep disorders are a common co-occurring or alternative factor. These are screening tools that you could use to look at some of these comorbid factors. The CDI, Depression Inventory for depression, the SCARED, which is for age 7 and up, and the GAD-7 for age 11 to 17. And the patient health questionnaire would be for depressed mood, and again, focusing more on the teenagers starting at about age 11. And the social communication questionnaire that you heard from Dr. Mohideen to consider if autism is within the differential that you're concerned about for your patient. I'd like to take just a moment to talk about sleep disorders. I work in that clinic here at Michigan Medicine, and I just can't tell you how overlapping the children with various sleep disorders and attention and learning and irritability and moodiness during the day can be. So thinking about sleep disordered breathing, about 30% of children have snoring, but 1 to 3% have what we call obstructive sleep apnea. And this could be as subtle as upper airway resistance syndrome, where it's really maybe the rate of flow isn't enough yet to cause that snoring, but you have low flow and hypopneic events. Signs of snoring, signs of OSA may include snoring, pauses, restlessness. But for a child, especially for children with genetic conditions where they may have lower tone, they may not be able to propel the air enough to cause the snoring. And so more subtle signs to be watchful for include that restlessness, mouth breathing, and sweaty sleep. Dry mouth in the morning may be an indicator. Daytime sleepiness, hyperactivity, being tired but wired may be your best indicator as well. Risk factors we know include facial structure, so we know OSA runs in families, and that might mean a narrow face. Kids who have prematurity, that will put them at risk for ADHD as well, but that more narrow facial structure raises the palate and increases the risk for sleep-disordered breathing. Weight, obesity might be a factor, but it's less often than what we see in adults, and the evaluation would be a sleep study. Two movement conditions to be aware of are RLS and periodic limb movement disorder. RLS is common, occurring in 2 to 4% of children, and really requires a constellation of historical contributors. So it's not something that you necessarily do a sleep study for, or although the overlapping condition of PLMD you do a sleep study for to do the diagnosis. But RLS is really the urge to move that's occurring later in the day, beginning at rest. That urge is relieved by movement, and is, again, pretty common in children. Periodic limb movement disorder is a PSG diagnosis that involves repetitive kicking, but of a specific amplitude and rate that disturbs sleep. And these are overlapping conditions where iron deficiency can play a role. And there is newer literature suggesting that iron deficiency may play a direct role for ADHD as well. So be aware of those conditions. And then finally, is your child or your patient getting enough sleep? Just looking at sleep duration may be a really important screening tool in your office. Not just bedtime, but from bedtime, when is sleep onset time? Because oftentimes they aren't the same, and that's very true for teenagers. So sleep onset time and wake time, and the National Sleep Foundation has some guidelines for you for expected sleep durations or your targets. This is a screening tool that has been validated in pediatric practice, the BEARS, that outlines each of the letters outlines a specific area to ask about, and I have added the restlessness for sleep-disordered breathing and RLS, or periodic limb movement disorder, categories. So the R is my addition. So now for treatment. This is from 2009 and is a survey, a national survey, where blue is the percent of medication treatment, and the yellow circle size is the percent of behavioral treatment by state. So you can see that there's a fair amount of variability nationally. In Michigan that year, the medication treatment was true for about 88% of people responding, behavioral treatment for 44%, and both for about 36%. So what do we recommend? First, we recommend that ADHD be cared for really within a medical home. This is a chronic condition and is no different in terms of the needs for coordination of care than diabetes or other conditions that we typically think of a medical home for. But by age, we have from studies, including the MTA study, looking at the benefit of behavioral treatment versus medication or both, that preschoolers are best benefited by behavioral treatments first, reserving medications if and only if there are moderate to severe risks for that child. And in fact, we know that medications have a greater likelihood of side effects for preschool age. At school age, both medication and behavioral therapies may be helpful, but by adolescence, medication therapy really takes the fore, with less benefit for behavioral treatments, at least from studies thus far. So the psychosocial treatments that have been used for ADHD include behavioral training, peer interventions, classroom management training, and then for adolescents, organizational skills. I apologize, I'm going to move a little faster. There is no evidence that cognitive behavioral therapy is beneficial in the context of ADHD, but it might be if there's a comorbid anxiety disorder. You might, in your practice, be able to use a daily report card for ADHD in collaboration with the school or with the family. And the NICH cue toolkit for ADHD can provide you the materials to really set up, decide on some target behaviors, and set up that reinforcement system. Medications for ADHD you likely know well and include the psychostimulant medications, which are first-line treatments for ADHD. The AAP in their guideline recommends starting with methylphenidate, largely because there are more studies of methylphenidate than the amphetamine agents. Both groups have immediate release and long-acting agents available. Side effects include decreased appetite, irritability, headaches, and maybe some effect on linear growth apart from effect on weight gain. It's important to monitor the efficacy and the duration. So when I have a family that comes back, I'm interested in what's the onset time, how long is it acting, and how efficacious is it, to get an idea of the dose and whether that particular preparation is the right fit. Second-line or third-line agents include the next two categories. One is the alpha agonists, which can be an alternative for ADHD treatment or an adjunct to ADHD treatment and allow you, along with the psychostimulant agents, to be able to reduce the dose of the stimulant if the side effects are too high and maybe cover the whole 24-hour day a bit better. Also, this group of agents may be helpful if there's a comorbid tic disorder or anxiety disorder. It's really important, though, that the families you work with know that these are different from the stimulants. You can't just start them and stop them. You need to come on slowly, and if you don't like what you see, you need to wean it off. And that is because of the effects on blood pressure, and that it takes a few weeks to see effect, that you may not see the effects quite so immediately. And the same is true for atomoxetine. And for this agent, it's important to start at half the dose. Otherwise, you'll risk significant side effects of nausea, vomiting, and sedation. And so if somebody takes the weekend, a week off on their vacation, it's important that they know they need to start back on half dose and then go to the full dose, or those risks will recur. Educational supports are available and important, especially for the children for whom you're concerned about a comorbid learning disability. Oftentimes nowadays, getting a 504 may be the best you can do for your child with ADHD. But that can provide some accommodations in the classroom, like preferential seating, a set of books at home for the child who's forgetful. So monitoring in the medical home requires frequent visits at the start to make sure that your regimen is optimized. And then the AAP recommends quarterly for the first year, and then 2 to 3 times per year thereafter to be monitoring vitals, weight gain, height gain. For any comorbid factor that may come in, like anxiety or mood disorder, you might have implemented a daily report card and would like to see the results of that, as well as school progress on treatment. And finally, treatment adherence, which for adolescents can be a really big deal, because adolescents in general think that kind of overestimate their abilities and don't think they really need to continue treatment, and that's particularly true for ADHD, and exacerbated by having ADHD. And there's a biology behind this. We know that gray matter is changing throughout from puberty on, so that there is synaptic pruning and development that's actually going from the back to the front. So what that means is that these important sort of prefrontal cortex and executive functioning abilities is later to get better. So that puts adolescents at risk for problems with risk for substance abuse, and we know that staying on medication treatment is really important to reducing the risk for substance abuse. So adolescents who have alcohol use disorder compared to teens with problematic alcohol use are 2 times more likely to have alcohol use disorder in adulthood. So it's a big deal to meet with your adolescent patients and contract with them, let them provide additional education about the risks for ADHD and see them back to assure that treatment adherence is maintained. And then finally, pharmacogenomic testing is really coming in. There are a lot of studies in adults looking at how an individual's sort of gene makeup might predict what medication is the best for them. However, the studies in children are really coming in, and we at Michigan Medicine haven't yet been using this strategy, but I know as I've received patients in consultation, many members of the community are. But I think that in the future, this will will be very powerful as we're looking for which agent is not only the best for that targeted treatment, but which is the best for less side effects. So when to consider a referral: when there's a poor response to medication, or you need assistance with case coordination, or if there's another comorbid condition that we could be helpful with in terms of getting you to the right place for that evaluation. Some of the resources are listed here, including my group in Developmental Behavioral Pediatrics, and I took the liberty of listing child and adolescent psychiatry in the MC3 program that has, I think, just been, as I've heard from primary care providers across the state, has really made a big difference in your care treatment, where you can have a psychiatrist on the phone who can answer those questions that you have in real time. And a majority, I would say, of the counties are now covered in the state. Yes. And I know at Michigan Medicine we have integrative behavioral health. That's where a psychologist is right there embedded in the clinic, and that has been very helpful too. And then here are national resources available to you for some of the things I've talked about today. And again, thank you very much for the opportunity to speak to you.